So I bet most people didn't know that colorectal cancer is one of the more common cancers in the United States. A lot of people think this is somewhat rare or this doesn't happen to many people because it hasn't had a lot of press. And I think that that's unfortunate because it is the second leading cause of cancer death in the United States. And I think what's particularly unfortunate about that statistic is that it's a completely preventable cancer. So with appropriate screening, this is a cancer that could, in theory, disappear. So I think that's something to keep in mind. So unlike some of the other cancers that we treat where there are no effective screening tools or established ways to screen, here we definitely have tools and we have an established protocol and we just need to follow it. So about half the people who should have had a colonoscopy or some sort of screening by age 50 or 60, depending on who you read as far as the statistic, have never had any kind of exam. And that's really the tragedy, is that many people choose to never have a test, whereas some people probably have too many. So we kind of have a disproportionate screening where we're screening the same people over and over again, but never get to at least half of the population. And we do start at age 50 for most patients. That's usually the magic time when we ask you to start the screening process. And the reason that it makes sense to screen this disease is that it's one that evolves slowly. So it starts typically as a polyp. The polyp can get bigger and bigger to the finally we end up with a colon cancer that is no longer a polyp and can become invasive. And at that point, we've probably entered this a little bit too late. So we want to be closer to the beginning end where we find polyps and we remove them. And I do colonoscopy 3 times a week, and I do usually about 10 or 12 a day when I do them. And I'm going to find a few polyps. And the idea is that I'm supposed to actually find them and remove them. And the single most protective thing to prevent colon cancer is having had polyps removed at colonoscopy. So if you look at people who end up not getting colon cancer, the differentiating factor largely is the fact that they've been screened. So that's the single most protective thing about all the things we're going to talk about. And the progression can be very slow. It may take 10 years for a polyp to turn into anything important. And that's the whole rationale behind the screening and why we do it typically every 10 years, because there is that very long lag phase. But if you've never been screened, then we'll never get to that 10-year lag phase, and we'll find something more advanced. And we need to start at age 50, where we have the most potential to find early lesions. And I have too many patients who come to me for their first exam when they're 80, and at that point you could argue you've kind of missed the boat. So we really want to get people really as they're younger and when we find things a lot earlier. So what causes colon cancer? If I knew the answer to that question, we'd be out of business and really rich. But there are no specific causes. But we know that these things actually increase the risk. And these are factors that we think of as far as mitigating risk and reducing risk. We can't make people younger, but if you're over 50, the risks start to increase. And that's really the break point of where screening starts to make sense. So that's why we start screening at age 50. Family history of colon cancer, and the more people that have it, and the younger that they have it at, the more concerned we get about that. So it's not only the number, but also the age at which they were diagnosed. And these guidelines are going to be for generic patients who don't have particular risks, but there's some patients who start getting their colonoscopies at 20 because they have such a strong family history. But in general, it's age 50 unless there's a special risk. Diets rich in fat and red meat, especially preserved red meats. We actually did some studies here, and one of the most colon cancerogenic things is preserved meats like cold cuts and things like that. So for whatever reason, the combination of the red meats and the nitrates seem to be particularly bad as far as risk factors from a diet perspective. So a healthy diet with lots of different colored vegetables and fruit is better. And colon cancers are relatively rare in the developing world. So if you go to countries that are a lot less well off than we are, they don't have a lot of colon cancer. And it may be that it's because their diets are healthier. And when they move to the United States, they get the same risk factors that we have. So it seems that our diet is doing us in a little bit here. And we'll know probably more about that in the next few years. Heavy alcohol use and smoking are both risk factors. And then tying in with diet, obesity, diabetes, and lack of exercise. And for reasons we don't know, and maybe some of these other reasons kind of contributing, African Americans have a higher risk, and many of us are suggesting that African Americans get their first colonoscopy 5 years earlier than non-African Americans. So that's kind of up for debate, but that's kind of where we're moving at this point, is because they present a little bit earlier and their outcomes have been worse historically. Symptoms. We're talking about screening today, so really you should have no symptoms to have a screening exam. That's the whole purpose of the exam. So the people we're actually aiming at when we're talking about screening are people who have no symptoms whatsoever. So a myth out there is that patients need to have symptoms before they would merit a colonoscopy, and that's totally false. We want them to have no symptoms. And we think that symptoms generally correlate with a more severe presentation and more advanced disease. If you were to ask me what symptoms would prompt a colonoscopy, these are some of them. A change in the bowel habits, especially if the stool becomes more narrow, or changes in, for more than a few days. It's certainly normal to have that happen every once in a while. But if it's consistent, that's a reason that we would want to see somebody. This would be particularly for a rectal cancer, a feeling that you have a bowel movement, but when you go, there's really nothing there, and then you don't really get relief after you have a bowel movement. So this unusual feeling of fullness in the rectum is one. It can come from other things, but it's one of the symptoms that would make us look. Blood in the stool for sure, no matter even if you had a history of hemorrhoids, that we have to prove that it's nothing else. So I think that blood in the stool always merits an examination. Unintended weight loss and weakness and fatigue. Unfortunately, those are very end-stage sort of symptoms, but those are some of the symptoms. But again, we want to focus on asymptomatic screening. So why doesn't everybody get a colonoscopy or some sort of screening? And I think a lot of this is about prevailing myths that people have, and we should maybe address each one of those myths. So somebody's decided that it's a men's disease, and it's actually 50-50, so there's no preference for one sex over the other. Typically doesn't hurt at all. So most patients, when they have the exam, don't remember the exam. They're sedated, and they have usually no recollection when I go to visit with them. Not only do they don't remember the exam, they don't even remember that they even came, and they seem to ask the same questions: when we're going to start, when are we going to get started, and we're all finished and they're eating. So that's very typical. And having had my own colonoscopy this year for the first time, I didn't remember anything, even going there. So I mean, it's really quite simple in that regard. I won't lie to you, the prep isn't any fun, but it's gotten to be much better than it used to be. So the prep is down to 1 liter versus a gallon, which is a lot less. It doesn't taste as bad as it used to. There's a flavorless prep that's coming in the next year. So we certainly are making strides. And it's one day out of your life where you eat less and lose a few pounds and drink something. It's really not too horrible. And we're looking at it right now. The preps I use today are 1 liter preps, which are split. So each one is only like one normal bottle of like a bottled water twice. So it's really much simpler than it used to be. So that is certainly the only part that's at all uncomfortable. Then we get this one. What's the point of doing this if colon cancer is not preventable? And certainly I can show you lots of evidence that it is. And that finding it earlier makes a huge difference as far as outcomes. So that part is really important. So the what's the difference thing really doesn't hold any water. We talked about symptoms, so that shouldn't be a reason not to get screened. It's risky. Well, getting colon cancer is risky too. So the incidence of a complication from a colonoscopy is around 1 in 5,000. So if you do 5,000, you should have one complication or so. So in the end, it's a very infrequent event. And most days I get up, I do 12 colonoscopies, I don't even think about them, and nothing happens. So that's typically the day. So it's usually pretty uneventful. And people think it's expensive. Well, it's usually free. So if you have Medicare or really anything, preventative benefits are usually 100% covered with zero out of pocket. So for most patients, if we're doing this for screening, there should be no charge. So there's really essentially no reason not to, if you think about it, other than the fact that people just don't want to think about it. But if they do, most of these are myths. And so if it's free, if it's going to prevent colon cancer, if it's not a big deal, why don't I just get it done? So I mentioned this before, that having had a colonoscopy, you can look at all the other things that you can do for prevention. And the single most important differentiating factor is having had a screening exam. So that's very clear, and there's no question about that. So what I put up here for you, and I actually sit on a committee that writes these guidelines for how to screen the population in the United States for colon cancer. There are other ways to do this. So I would be giving you a lopsided presentation if I only spoke about colonoscopy. So I'm going to go through all the other things that are available, and then you would make a decision with your doctor. So I'll start with colonoscopy, since we've been talking about that. It's done every 10 years, unless we find polyps, and then we bring you back a little bit sooner, either at 5 years or 3 years, depending on how many. And with family history, we usually do it every 5 years. We talked about the prep and the complication rate. And the bottom line is, how often do you find cancer? And then a secondary question is, how often do you find polyps before they become cancer? So at least as far as cancer detection, for colonoscopy, we're at 95%. So if there's a cancer there, we're going to pick it up 95% of the time. And for polyps, we're around 80 to 90%. So we find most polyps, and we get rid of them when they're there. The other screening strategies all have their pluses and minuses. The standard stool cards are called guaiac cards. They're done yearly, so if you don't do it yearly, it doesn't qualify as a reasonable screening process. So you have to do it every year. There's no prep, so that's an advantage. There's no risk. But if it's positive, you have to have a colonoscopy anyways. And it's only picking up 20 to 30% of cancers. So that may not be acceptable for most patients, but it is still an accepted screening tool. The next generation, which is what Kaiser largely is doing, is FIT testing. So this is second generation. The guaiac test, the card, is picking up hemoglobin, or actually just the proteins from blood, and it can cross-react with animal blood. So if you ate meat, for example, it can give you a positive. The FIT testing is more specific to human hemoglobin, and it's much more accurate. So this is the better kind of stool card testing. So if somebody offers you this and you decide you want to do stool cards, ask them for the FIT testing rather than the standard cards. No prep, no risk. Still have to do a colonoscopy if they turn positive. And we're detecting cancer somewhere at the higher end of this, maybe 70 to 80% in the last studies if you do the test right. So it's pretty sensitive at picking up colon cancers. But again, it's not going to pick up polyps. And if it's positive, you're going to end up with a colonoscopy anyways. FlexSig, we generally aren't doing much. This is a shorter colonoscopy, essentially. It's a limited exam. It's going to miss everything in the right colon because we're never going to get there. It has the advantage of having an enema prep, which is easier, but it's got no other real advantages. The risks are a bit lower, but there is still a bit of risk. And it's going to miss most cancers, especially anything on the right side. And cancers seem to be moving in the right colon direction in general. So that's not, I think, a very good test to do. And if you did it, it would probably be done. This says yearly. I don't know that anybody's going to do this yearly, but perhaps every 3 to 5 years. But I really wouldn't recommend it. And the last one people ask me about a lot is CT colonography or virtual colonoscopy. And this is a CAT scan with some extra dye and a little tube with air in your behind. The problem with CT colonography is that nobody wants to cover it. So it's largely a non-covered benefit unless you fail the standard colonoscopy first. So that's really the only role typically for it is people who we can't get the colonoscopy done for a technical reason, and they could have this done instead. We think it would probably be done every 5 years. The prep is exactly the same as it would be for a colonoscopy, which is the major factor. There is radiation exposure because it's a CT, and if positive, it requires a colonoscopy because we can't diagnose or take any pieces of anything. And it's pretty good at picking up cancers, and we don't know how good it is at picking up polyps. So that's kind of the landscape of what's available. All these are acceptable, and the one that I would suggest that's the gold standard would be a colonoscopy every 10 years. The last thing I'm going to show you is a little forward thinking. And in the New England Journal of Medicine yesterday, they published the results of this new technology on stool DNA testing. And this may be the future of testing for all GI cancers because most cancers shed abnormal cells into the stool. We've been trying to get this technology off the ground for the last 5 or 7 years, and it's finally, I think, gotten to be ready for prime time. And at this point, this is something that I think is going to be talked about a lot in the news and kind of in the future what we decide to do for the population in general. It's not yet FDA approved. I think it's going up for approval in about 2 weeks. We don't know if insurance is going to pay for it. It's a single stool that you actually produce for. They give you a little hat, you put it over your toilet, and you produce a stool. And you actually put it in a box. You call FedEx, and they take the stool away. And they take it to a lab in Madison, Wisconsin. They open the box, and they process the test. And what they're able to do is actually look for certain genetic, it's not genetic testing, but certain genes that are sloughed in your stool that mark you for colon cancer. And the study that was published yesterday showed that 92% of colon cancers were picked up with a single stool. Disadvantage is that you're going to need a colonoscopy anyways if the poop test is positive. But for patients who are unwilling to do anything and don't even want to talk about this, it's a decent option out there for people once it's available. It's not available yet. Now, as far as picking up polyps, we don't really know how good it's going to be at doing that. But the study that they published yesterday showed about 48% of patients that had big polyps were picked up on this test, so about 50-50. But a lot more promising than what we've kind of seen in the past. So we think that in the end, this may be the future of things. But right now, I think of this sort of the entry-level test. And then if you really don't want a colonoscopy, it's better than not doing anything at all, but probably not as good as having a colonoscopy. But for patients who refuse, this is going to be a good option. We just don't know how much it's going to cost and how often to do it and who's going to pay for it. But that's kind of coming in new. And we're thinking other cancers, too, from the GI tract will be screenable using the stool methodology. So this is kind of coming in new and very interesting. So you'll hear a lot more about that in the future.
Okay. Hi, I'm Steve Sentovich. I'm a colorectal surgeon. You might wonder what that is. It's somebody who, after medical school, did 5 or 7 years of general surgery training, and then subsequent to that, did another 1 or 2 years of training just on colon and rectal disease. So I focus on both benign and malignant cancer disease of the colon and rectum. So colon and rectal surgeons are really the experts in colon and rectal disease because this is what we focus all of our time on. And the role of surgery in colon and rectal cancer is really pivotal. Surgery is really the primary treatment for colon and rectal cancer. And because our blood tests and x-rays aren't as accurate as we'd like, it's really surgery is the primary means that we stage patients and give them a prognosis because it's only once we've removed the cancer that we can figure that out in detail with the pathologist's help. Finally, because of all that, surgery is really the primary means by which we determine whether or not somebody needs additional treatment, such as chemotherapy or radiation therapy. There are a number of myths about surgery. Perhaps the most common is that all surgery for colon cancer involves a colostomy. This is an absolute myth. There are a very small number of patients who might need a colostomy when their tumor is really very low in the rectum. But the vast majority of patients do not need a colostomy. Certainly all colon cancer patients where it's not in the rectum in most cases, don't even need a temporary colostomy. Some of the rectal cancer patients do need a temporary one, but really, most colon operations do not need a colostomy. The other thing that has come up over the years is that when you open the belly, then the tumor spreads around everywhere. That is also not true. A lot of times, in the past, maybe we didn't do the studies to know if the tumor was someplace else or the studies were inaccurate. Our studies are better now, but they can still be inaccurate for a small amount of disease that were unsuspected. So surgery, just doing the operation, doesn't spread the tumor around. Now, in this slide, I want to emphasize what's on the right-hand side here, that the earlier a colon cancer is detected, the less invasive the procedure we need to do to basically fix the problem and cure you, as well as the faster the recovery is and the higher the cure rate. And so let's talk about these various operations for colon and rectal cancer. One operation is actually a colonoscopy. If you have a colonoscopy and a polyp is removed, and that polyp had a little cancer in it, that could be the end of your treatment. It's gone, it's removed, and you don't need any surgery. So there's no incision, there's no stay, you just had a colonoscopy and your polyp's gone. That's when you have just a little bit of cancer. If you have a little bit more cancer and it's down in the rectal region, We can do a hemorrhoid type operation to remove the tumor, and this would be an operation that's associated with maybe just an overnight stay or a same-day surgery, no abdominal incisions or anything. The tumor's gone, and that's the complete treatment. If the tumor's a little larger and up higher in the colon, then you actually need an operation in your abdomen. But for most patients, we can do this in a minimally invasive way using either robotic or laparoscopic surgery, which actually minimizes the size of the incisions. There's a little quicker recovery, less pain after the operation, and it's associated with a shorter stay, like 2 to 5 days or 3 to 5 days, typically. If the tumor is larger or more involved, sometimes you just need to do a standard open type operation, which is associated usually with a 3 to 6 or 7 day hospital stay. So really the difference, people make a big deal about the technology, but the difference is a little bit in terms of discomfort and pain, and then the size of the incision, but not much in terms of the hospital stay. So what does this technology look like? Everybody wants to see all of our new tools. Well, the standard open operation is right here, where we do usually an incision kind of in the midline to access the belly and the colon. And in laparoscopic surgery, we make small little poke holes and put these little ports in the abdomen. And then through those ports, we place various instruments, including a camera, so we can see what we're doing. And we can do the exact same operation that we do with the open incision. And that's very important because you want to have the correct cancer operation. So if you can't do the correct cancer operation using this technology, you should make an incision and do it the right way, because that's the most important thing, curing you of cancer. So to give you a better idea of that, I have a little video demonstration of the laparoscopic. This is just a schematic. It's not a live. So the patient gets draped, and then the ports are placed. And you can see in this instance there's 5 ports. So you're going to need 5 hands. At least you need 3 people to manipulate all these instruments. You've got a camera, you've got suction, you've got scissors and various other instruments, graspers, in order to do the operation that you need to do. And with the surgeons alongside the patient and their hands on these long instruments that go through the port, you can look up at the screen and at what the camera is showing you, and you can do the entire operation. So that's what laparoscopic surgery looks like. What does robotic surgery look like? The patient is on the table with the ports in place, just like we showed in laparoscopic surgery, but instead of a bunch of surgeons around, the robot holds all the instruments. And the surgeon sits at a console, and one surgeon can manipulate all these instruments. So it includes the camera and the graspers and the scissors and all those kinds of things. Because the instruments are connected to the robot, the instruments are a little smarter than the instruments in laparoscopic surgery. They can move in different ways, and the surgeon can control them in different ways. You can see the surgeon's hands are in here. They're on these little devices here that control each instrument and move each instrument. So in addition to the degrees of freedom that you get with the instrumentation, you also get a 3D depth that's a little better than the laparoscopic surgery, because you're looking through this screen here. And I have a little bit of longer video clip to show you about robotic surgery. So you're looking through the robot right now, and you're looking at how these little instruments work here and how you can manipulate these little graspers. And we've decided to grab a piece of paper and do a little folding exercise. And there you can see how the surgeon uses his or her hands. And you can see how precise the work can be with these robotic instruments. This kind of precision is not possible with the standard laparoscopic instruments, and has made some operations doable that we couldn't do laparoscopically. So you can see they're still folding here. You probably guessed what we're doing here. we're making a little paper airplane with the robot. Now, we actually do surgery with the robot, but this is for demonstration purposes. I think the big thing to see is how precise the work can be, as well as how the instruments themselves can move. That really is an advantage. And so in tough places that you can't really get to laparoscopically, you can get to robotically with very precise instrumentation. And once we get that airplane done, we'll show you a little bit about how big that airplane is. So you can see how precise the work is here. And you can see how the instruments can move. So that's a good demonstration of what the robot can do. We're trying there. Flight. So if you're a patient and you walk into my office and you've got colon cancer, how do I approach the situation? Well, the first part of the surgeon's job is to kind of listen to what you're saying about your concerns about what's going on, your symptoms, as well as hear about what you're thinking about your treatment planning. Because both those are very important, particularly in rectal cancer where there's a lot of options. And then we need to discuss in detail all of those options, giving you the benefits and risks of each procedure, and then determine the optimal treatment. Now, you can look in a textbook, and I can give you, and oftentimes I'll say, this is the textbook answer for this problem. But the timing of when we do that, how we do that, some of your concerns about what's going on, all factor into the treatment plan. Then you need to perform the best operation possible to cure the cancer. And as I mentioned earlier, just using technology, using a laparoscope or using a robot doesn't necessarily mean you're going to get cured. And so you need to do the best operation. And in a lot of cases with cancer, and particularly of the rectum, that may mean that it should be done at least hybrid laparoscopic and open, not necessarily pure laparoscopic, because some of these procedures are very technically demanding. And finally, you need to monitor the progress and recovery, particularly immediately after surgery and then long term. We like to follow patients for about 5 years after colon cancer. It's unusual for the cancer to come back after that. Most people are cured right off the bat, but we don't know, and so we have to watch you for about 5 years to make sure. Finally, I'd like to conclude with this slide about the uniqueness of our program here at City of Hope. All of us are really subspecialists, like myself, in terms of the surgery part of things, and really our studies have shown that outcomes are really better, when you have somebody who does this all the time. We do offer all the various surgical options, including the minimally invasive options. I think it's also important that we get together actually twice a week to discuss cases, and everybody's there. There's surgeons, medical oncologists, radiation therapists discussing cases to figure out the best treatment plan for you. Once the treatment has been initiated and you're in the hospital or recovering, there's a singular goal between all the caregivers to really give you comprehensive care and see you through the whole process. So I thank you for your attention, and I'd like to turn this over to Dr. Fakih, our medical oncologist expert.
So I'm a medical oncologist, and I see predominantly colorectal cancer, and I see stages 1, 2, 3, and 4. And I was thinking about what I will be talking about today, and what I thought I would talk is, well, what do patients need to know when they come to see me? Because when somebody comes, they're overwhelmed with their diagnosis. They don't know what to ask. They're scared to ask questions. They're not sure what to ask. And unless I prompt them or tell them, well, this is what you should ask, or this is what you need to know, they may leave uninformed. So I made a list of 10 questions. And I titled my presentation, Now That I've Been Diagnosed with Colorectal Cancer, What Should I Ask and What Should I Know? So the first thing that somebody should ask is, what is their stage? And what does it mean that my stage is 1? What does it mean that my stage is 2 or 3 or 4? Well, the first thing that we need to tell patients is that even if you have stage 4 disease, which is the most advanced stage, some patients with stage 4 disease are curable. So the first thing is that there are reassurance that there may be a cure for some stage 4 disease. The second thing that I tell patients with stage 4 disease is that even if you have a cancer that has spread to your liver, it's not hopeless, because we cannot cure diabetes. We cannot cure hypertension. And I'm not belittling cancer. I think cancer is very serious. I think it's a serious diagnosis. It requires serious treatments, a lot of sacrifices from patients, families. But I think it's important to have hope that with treatments, even if they're continuous, that we can control the disease. And the fact is that people are living longer with even advanced stages of colon cancer. But we have to keep our eyes on any possibility of cure, even if that means liver resection for some patients with stage 4 disease. So the first thing that I would discuss when a patient comes to my office is, what is your stage? And basically we have 4 stages of disease. And I'm not going to go over the details, but the early stages of cancer that are limited to the colon often are treated with surgery alone. And if there's no spread to lymph nodes, and unless there are some significant risk factors, such as a perforated tumor, many of those patients can be observed without chemotherapy, and their prognosis is very good. However, patients with stage 3 disease have a higher risk of relapse, and those patients will need chemotherapy. And patients with stage 4 disease are more advanced because the tumor has spread already to distant organs. It may have spread to the liver or to the lungs. And so what I discuss with the patient is based on their stage is what to do. Now, I'm going to take you through the earlier stages first, and then we'll go to the more advanced stages. So if I am a patient who has recently had surgery, and often those come after capable hands have done their surgeries, and what should the patient ask me? Well, they should ask me, now my cancer is out, what are the chances that the cancer would come back? And that is determined now by not just looking at their stage, but there are more fancy tests, molecular assays that we can do to figure out what are the risks, for those individual patients. So to give you an example, stage 2 disease, it means that the tumor is in the bowel wall, but it has not gone to any lymph nodes. And in general, those patients have a 15% chance that the cancer has spread outside the colon prior to their surgery. Which means even if we do CAT scans and even if we do blood tests and we see that there's no signs of cancer, there's some cancer hidden somewhere in the body that may grow with time, and that's when the cancer reappears. I often tell my patients that when we say your cancer recurred, it's a misnomer because it never left to recur. It's not kind of a magic where somebody is cured and then the cancer comes back. When somebody had colon cancer resection and we find later that there are spots in the liver, the tumor had spread to the liver before their colon surgery has been done, but it was too small to be found. So besides the staging of these patients, besides looking at CAT scans, doing blood tests, for stage 2 disease where there's 15% chance of recurrence, we can do some gene testing on the tumor, and we can actually stratify these patients further, where we can tell somebody your risk is not 15%, it's actually 8%, because we've done a more accurate assay on the genes that determine your cancer to spread. Or your cancer is actually not 15% chance, but it may be more like 20%, and now we are telling you you may actually benefit from chemo to reduce those risks. So at least from the perspective of what we call prognostication, being able to tell that the cancer may be less likely to recur or more likely to recur, that's helpful for the patient because they know what their risks are, and we can really kind of at that point go over the merits of doing chemotherapy for 6 months, which may cut the risks of the cancer coming back between 30 to 50%. All right, so the other thing that I always talk to my patients about are what are the benefits of chemotherapy? Often patients don't ask this question, but in their mind is, well, yeah, you're telling me my cancer is going to have a 30% chance that it would come back, and if I get chemotherapy for 6 months, it will go down to 15%. Why would I want to do that? Why don't I wait till it comes back, if it's ever going to come back, and then deal with it, right? There's a 70% chance I'm doing chemo for nothing or even more. And the reason for that is that you want to prevent or sterilize the microscopic metastatic disease. Because if you don't, and it reappears in the liver or in the lungs, the chances of us being able to cure it surgically is much lower. It's not 0, but it's not that high. First of all, if it does come back with multiple spots, we can't always cut them out. It's usually only about 30% chance. And second, the chances of cure at that setting would be lower. So we want to prevent it from coming back by actually taking care of the microscopic disease if we can. So that's the reason we advise chemotherapy in higher risk patients. Patients who have very low risk, you know, we do not, because there's no clear evidence that the chemo would help, number one, and the risks in some patients may outweigh the benefits. So we've talked about why do chemotherapy for stage 3 disease. And then the second question would be, what are the treatments for my stage 3 disease? And, you know, in oncology, it's a science of basically evidence-based medicine. So we don't really kind of make a decision in the office that, oh, we're going to do this chemo. These are based on clinical trials. These are based on large studies that have looked at patients who got chemo versus no chemo, certain types of chemo versus other types of chemo. And we could be using a more aggressive chemotherapy for higher risk patients, and maybe even just a chemo pill with very little side effects for lower risk patients. And we go over those discussions in the clinic, and we show the patients graphs as to what their risks are with and without chemotherapy and the benefits from chemotherapy. And it's really a decision not that the physicians alone will make. This is a team effort. This is a patient and physician decision, and we go on attacking or tackling the problem together. So the other question should be, what are the side effects, and can I live with chemotherapy? And the answer, yes. And there are side effects, but they are manageable. The average age for colon cancer in the United States, the median is 70, so meaning half of our patients are older than 70. And yet I can tell you that patients who are treated with chemotherapy can go on and golf, they can play tennis. Yes, they are limited. Yes, they have some bad days. But in general, people live their life. And I tell them to travel, and I tell them to go and dine and explore any kind of activities they like to have. In general, the more active, the better. We discussed the side effects. Some of them are fatigue, some of them are mild nausea or diarrhea, but in general, with the medications we have for supportive care, those are very, very manageable. So then the question becomes, well, I'm 80 years of age, should I be doing the treatment? Is that too old for treatment? Is that too old for chemo? And the answer is no. If your risk of recurrence is 40% and you're 80-year-old and fit, you may actually have another 10 years to go. And so the data suggests that elderly patients will benefit as much as younger patients. That doesn't mean that we are cavalier with chemotherapy and give them the hardest chemo possible. We have to kind of balance what they can handle, but we have to keep an eye on the potential benefits of treatment. But in general, mild chemotherapy, such as a chemotherapy pill, can be handled very well by elderly patients. And okay, so now I have stage 2 or stage 3 colon cancer, and you told me I'm going to do chemotherapy. What does it mean after chemo? So first of all, for prevention for stage 3 disease, we use 6 months of chemotherapy. But we're not out of the woods. All what we can tell the patient at that point is that we've done the best we can to prevent this from coming back. We can tell them if your risk is 50%, we cut it down to 25% that it will come back. We tell them that we need to monitor them and survey them. Why? Because if this comes back and it's limited to 1 or 2 or 3 or 4 spots sometimes in the liver, we can cut them out. And we can cure some of those patients. And even if we cannot cure all of those patients, they typically live longer when we are able to successfully remove the metastases. So we have to keep a very close eye on patients with high-risk disease. We have to scan them and image them. And a lot of patients tell me, I don't want to get a scan. I'm afraid of the radiation and the risk of radiation. And I tell them that in that setting, those studies that you are alluding to are for patients who go to ER and have a scan every 3 months for back pain. And in your case, the benefits from scanning and follow-up far exceed a minuscule risk of increased risk of having a secondary cancer from radiation 20 years later. So we have to survey those patients. We survey them with tumor markers in the blood. We survey them with scans. And they obviously have to have colonoscopies more often than the rest of the population, 1 year after their surgery and subsequently every 3 to 5 years, because they're at higher risk of having another new colon cancer because they're already predisposed to get colon cancer. So surveillance is very important. When I was in my prior institute, we looked at our patients, more than 100 patients that we surveyed aggressively with scans every 6 months in the first 2 years and then every year. And what we found is that 60% of those who relapsed, we were able to take to surgery. And their survival was extremely better than patients who were not surveyed or had a higher stage of disease, and many of them were cured after another resection. One very important question is that, so you're doing all you can to prevent my cancer from coming back. What can I do? to stop my cancer from coming back, right? You want to be proactive. And I think we are all bombarded with alternative care medicines, complementary alternative care, juicing, you name it, it's there on the web. You name any over-the-counter supplement, there's a claim about a cure. So what to do? And again, you know, some patients have very strong feelings about certain supplements, and if it does not interact with their medications, we're not opposed to that. There are, however, some medications that may interact, and we ask them to tell us what they're taking. But what I tell patients is that, yes, you can be proactive. Yes, there are definitely some things that have been associated not just with prevention of colon cancer from coming back, but have been associated in studies of a decrease in recurrence of colon cancer. Somebody with stage 3 disease who got chemotherapy. If you look at those patients who exercise regularly after a diagnosis of colon cancer, those who exercise have a lesser risk of recurrence. And the more they exercise, the more the physical activity, the less the recurrence. So I do encourage all my patients to take a very proactive approach. It is difficult because they get chemotherapy and they're tired. They cannot exercise very well on chemo. But once they're done with chemo, they have to go through a program, and it's very good for them to start increasing their activity level. Diet was mentioned by Dr. David, and I think that's also important to monitor after a diagnosis of colon cancer. Not only now there is data that red meat and high fat, what we call a Western style diet, is associated with a higher risk of relapse, but there's even some evidence that what we call a glycemic index is associated with a risk of recurrence. We always kind of shrug the notion that the sugar feeds the tumor, and it looks like it is possible that it does. There's some evidence that very high carbohydrate diet, and we're not saying you can cut carbohydrates, nobody should, because you need some carbohydrates. But a very, very high carbohydrates diet in one study have been associated with an increased risk of recurrence. So I tell patients exercise. I always tell patients a cardiac diet is your healthy cancer diet. So limit your fat intake, your red meat, and basically your servings of fruits and vegetables. So we're getting to the bottom of the list. Okay, the other thing I want to mention is you may hear about aspirin for prevention, and the data is conflicting. But there is evidence that aspirin reduces risk of polyps. There's no question about that. We know that aspirin reduces polyps. The issue with aspirin is that it can also cause peptic ulcer disease and bleeding, so bleeding ulcers. So we always have to weigh these things. I talk to my patients about it. If somebody has a low risk for bleeding, we talk about taking an aspirin a day. There's some data suggesting a potential decrease in relapse in the setting of aspirin. The problem is that these are what we call observational studies. They're not really well-done studies. They're looking back at patients, what did they take, questionnaires, but there is some signs that aspirin may reduce relapse. And so that's pretty much it about supplementation. I think it's diet and exercise and discussion of aspirin. And then the question is, my last question would be, what kind of studies does City of Hope do, and what are we doing for patients with colon cancer, and where do we stand with advancement in colon cancer? So I'll just go over a few kind of main points. Number one, as I said earlier, if we can't cure it, we hope to live with it for a long time, and we do our best to live with it for a long time, and there's a lot of options. Number two, we are in an era of what we call a targeted therapy era and what we call personalized medicine. So if somebody has advanced colon cancer, the first thing we do is we basically take a piece of the tumor that had been resected or biopsied before they came to us. We send it for a comprehensive genetic analysis. We determine what kind of abnormal genes are present there, and that will guide us as to what is the best treatment for those patients. So targeted and personalized medicine is important. Clinical trials are very important. We are looking at having options for patients who have gone through the available treatment options. So patients who have gone through 2 or 3 lines of treatment and did not have an ongoing response, we have many trials that are in the pipeline or open that are trying to offer options for those patients. We've talked about chemo. There's also a very strong radiation oncology program. We do targeted liver radiation treatments for patients with disease to the liver that is not resectable, that is not amenable to surgery. We always keep an eye on the ball. If a patient has disease that has spread that cannot be resected, we try to shrink it down to resection because we always want to shoot for a cure when we can. Last, as far as prevention, we are looking at a very exciting study right now. This is a large study going on through United States, looking at 2 agents. One is called sulindac, one is called eflornithine. And those have been associated with a 90% reduction in polyps in prior studies in patients with polyps but no cancer. So now patients with colon cancer who had a resected colon tumor are offered this combination through a clinical trial that is supported by the NCI. So we're looking at not only therapeutic studies, but also at prevention studies. So I hope that basically gives a nutshell as to management of colorectal cancer and the discussions and thoughts in mind, what a patient can do and what a physician can do for this disease.